Right. So as I introduced myself before, my name is Mark Gimbel. I'm a surgical oncologist, and I'm actually the medical director of the T.W. Lewis Melanoma Center of Excellence here at Banner MD Anderson Cancer Center. And this center has allowed us to offer this partnership with AIM at Melanoma and a lot of the work that we do here at the Cancer Center. So I'm excited today to present to you the surgical management of melanoma. For those patients who are of mine that are in here, you've probably heard me tell you this story when you came to see me, or this talk when you came to see me. Same for those online. But if not, I think this is a good overview of how I manage a patient who comes in to see me and we're considering surgery for melanoma. This is my disclosures. So essentially, the management for melanoma is based on the stage of the tumor. If we're going to consider surgery, that's typically on the earlier stages, stage 1 and stage 2, where the tumors are confined to the body. Stage 1, they're small and localized. Stage 2, they're a little bit thicker, but still localized. Then stage 3 and 4 are considered more disseminated. The cancer has traveled through the body to other areas. For stage 3, it's traveled to the lymph nodes. And stage 4, it's traveled beyond the lymph nodes, whether that's the lung, the brain, the liver, just another area. But for the surgical management of melanoma, it's the early stages. It's typically stage 1 or stage 2. And we define stage of melanoma based on how deep in the skin it grows. So in our skin, we have what are called the skin stem cells, if you will. They're the squamous cells, the basal cells, and the melanocytes, and all these can form cancer. And many of you may have had squamous cell carcinoma or basal cell carcinoma. Those are skin cancers, but not nearly as severe as the melanoma. And all these stem cells are in the epidermis. Over a lifetime, you get these you develop these mutations from all these environmental factors. If you have a somatic tumor, and the cells in the epidermis start to mutate, and they can form cancer. Well, if the melanocytes mutate, they form melanoma. And if it stays in the epidermis, that's called melanoma in situ. And by definition, a melanoma in situ cannot spread because it stays in the epidermis. But as the melanoma cells start to invade into the dermis, we're now talking about an invasive melanoma. And that's where surgery becomes a little bit more needed. And we also have to worry about risk of spread. And that risk of spread starts increasing as the tumor grows down into the skin. So I always have to assess for risk of spread. Now, the only way to identify how deep in the skin the melanoma grows is by doing a biopsy. So someone who has a suspicious pigmented lesion, they would see Dr. Abbott. She would say, yep, let's do a biopsy. We're not going to do that PLA. We're not going to do the patch. We're going to biopsy, take it out, and we're going to see how far into the skin this melanoma goes. And now once we know how deep it goes, now we're going to figure out what to do. So just to review this, the earlier stages, stage 1 and 2, you can see that I have these T1A, 1B. T means tumor thickness, and we can discriminate or at least measure how deep in the skin it goes to decide which stage. Early stage is going to, or stage 1 is going to be between roughly 0.2 and 2 millimeters in depth into the skin, and stage 2 will be 2 and beyond. For anything deeper, even a 10 millimeter melanoma, if it's localized, is still considered a stage 2 melanoma. The reason this is important for those tumors that are less than 0.8 millimeters in depth in the skin, typically the risk is so low that we don't worry about spread, that we cut them off. And if they're clear, there's no further melanoma, I would send that patient back to the dermatologist for continued surveillance. But once it goes beyond that 0.8 millimeter depth, the risk increases as spread. And now we're going to start assessing for spread. I got to start doing further things to make sure that the cancer hasn't spread. And so we know that the deeper it goes, that risk increases. So how do I assess for spread? Well, the way I assess for spread, we really have to think of how does melanoma spread. Typically, the way melanoma spreads, it spreads through the skin. It's a skin tumor and it spreads through lymphatics. And lymphatics are fluid channels that run all throughout your skin and drain the lymph nodes. So when we talk about spread of melanoma, we're really trying to assess if there's cancer in the lymph nodes. Now, when melanoma spreads to the lymph nodes, there's specific areas in the body where those skin lymph nodes are. There's essentially 3 regions that we have to be concerned about. For patients who have melanomas on the head and neck, the lymph nodes that the melanoma can spread to are typically up here along the jugular or the carotid. For those patients who have melanomas on their upper torso or the arm, the lymph nodes are going to be in the armpit, the axilla. And for those patients who have melanoma on the lower extremities and the torso, or in the lower torso or the extremities, the lymph nodes are in the groin. So it really depends where on the body the melanoma is going to predict where I have to assess for lymph node spread. One caveat to that is for patients who do have these thick melanomas that are greater than 4 millimeters in depth, If we go back to this picture here, that would be the all the way on the right side. You can see as the melanoma grows down, sometimes it can bypass the lymphatics and it can get into the bloodstream. It can go deeper. And then we have what's called hematogenous spread, not lymphatic spread, meaning it can get into the blood. And so for patients who have thick melanomas greater than 4 millimeters, I would actually get a scan ahead of time before any surgical intervention to make sure it's not someplace else. So, and if there is no evidence of disease on that scan, then we're still talking with stage 1 or stage 2 melanoma. And that's how I would define the pathway that the patient would need to undergo. Now we look at the spread. I've got to also consider, yes, it spreads to the lymph nodes, but when we're talking about lymph nodes in these certain regions, people have many, many lymph nodes in each of the regions. But when melanoma spreads, it doesn't spread to all of the lymph nodes equally. It'll typically spread to 1 or 2 lymph nodes first, and we call those the sentinel lymph nodes. So I don't need to assess all of the lymph nodes. So let's take, for example, a melanoma on the arm. If it's going to spread, it'll typically spread to the lymph nodes in the armpit. Well, in our armpit, we can have 20 to 40 lymph nodes, but the melanoma is not going to go to all of them equally. It'll go to 1 or 2 lymph nodes first, and we call those the sentinel lymph nodes. So many of you are aware of the concept of a sentinel lymph node biopsy. And what that means is I take out that first draining lymph node to see if there's cancer in it. If there's no cancer in that first draining lymph node, well, there's not going to be cancer afterwards. A lot of people will come to me and say, well, I want to scan. I've got a 1.5 millimeter melanoma. I want you to scan me to make sure it's no place else. No, that's not really the right thing to do, because when melanoma spreads, it typically spreads microscopically. We're looking for microscopic disease that's not seen on a scan. It's seen in the lymph node, and that's why I would take the lymph node out to see if there's cancer in it, but we're not going to see it on a scan, and I don't need to give my patients the added radiation just from getting CT scans if we know they have localized disease. And let me just move forward through that. Now, the only caveat here is if somebody comes in, and this isn't that uncommon, where they say, oh, I've got a little golf ball in my armpit, don't know where that came from. And lo and behold, they end up actually they find a primary melanoma, and the melanoma is already spread to the lymph node. This is called palpable or clinical disease. This isn't something I'd be looking for microscopic disease, because we already know that somebody has that melanoma in the lymph nodes. And once we know it's in the lymph nodes, now I am going to scan somebody to make sure it's no place else, because I don't want to miss having tumor someplace else, and I don't want to operate on somebody for regional disease if it's going to be in another area, and me operating isn't going to offer any benefit at all. If there is no distant disease and somebody who has a palpable lymph node or a clinically evident lymph node, then we would actually remove all the lymph nodes. I'm not just going to take out that one, we're going to take out all the lymph nodes, because we know that if you have disease in one that's significant, you could have disease in others, and we don't want to leave cancer behind. Before we go to the operating room, we actually will treat patients with treatments or therapies before surgery. We call that neoadjuvant treatment, and Dr. Mahmood is going to talk about this in a little bit, so I don't want to get in too much of into the weeds here, so he'll be giving a lot of details on that. So, as I said, let's go back to the example of the melanoma on the arm. It's going to spread to the lymph nodes in the armpit. I told you there could be 20 to 40, but how do I find the lymph node? How do I know where that sentinel lymph node is? Can't feel it. I'm not going to be able to see it. So the way we actually localize the lymph node is using nuclear medicine. Around the melanoma biopsy site, you come in and you get injected with a radioactive tracer. And that tracer gets put around the biopsy or around the melanoma, and it gets taken up into the skin lymphatics, and it'll drain to that same lymph node that if the cancer is going to spread to, that would be the lymph node it's going to spread to. So what this is going to look like is something like this. So this is a patient who has a melanoma on their back, a little off to the left side. You can see there on the top left picture, that center dark spot is the injection site around the melanoma. And then you can kind of make out that this is a person. You can see the arms off to the side, and off to the right side of the picture, the patient's left side. You can see another spot that shows up, and that's the draining lymph node. That's the first draining lymph node, the sentinel lymph node. And if you look at the top right square, you can actually see that lymphatic that shows up where that lymph node is draining. So we know that that's the first draining lymph node. And if the melanoma is going to spread, that's the lymph node it's going to spread to. So I need to take that lymph node out. I'm taking it out not because there's cancer in it. I'm taking it out to make sure there's no cancer in it. We want to look at it and say, no cancer in that. You're clean. We know your cancer hasn't spread. You have early stage disease. Same thing goes for the legs. So this is a patient who has a melanoma on their leg. You can see just at the cutoff of the bottom of the screen, there's a big dark spot. That's the melanoma. And you can start to see the lymphatics as they head up to the lymph nodes in the groin. And these are the two draining lymph nodes, one or two, sometimes there's more, just depending on how the lymphatics go, that are the draining lymph nodes and are the sentinel lymph nodes. And these would be the ones I would need to assess. Another example here, you can see a nice lymphatic heading straight up the leg into that first draining lymph node. Now, two show up here, but you can see it's very linear. So I only need to take that first draining lymph node in the leg, because if it's not in that first one, well, there's not going to be cancer in the second one. So these images really help me predict or determine what I need to do in the operating room. And to take these lymph nodes out, we do have to go to the operating room. Things aren't always easy, though. Body doesn't always do what you want it to do. Someone who has a melanoma right in the middle of their back, well, the body typically is lateralized. Things on the right go to the right. Things on the left go to the left. Things up go up, and things down go down. But what if you got one right in the middle? This is an example of someone who has one in the middle of their back, and it actually could potentially spread to both sides. Again, just because these lymph nodes show up here does not mean there's cancer there. It's the potential for spread. But I would need to check a lymph node in both armpits to make sure there's no cancer there. I've actually had somebody who had a lymph node right smack in the center of their chest or in their torso, and they've actually spread to all four. And so I would need to do an incision in both groins and do an incision in both armpits to make sure. Now, that's based on the risk of their tumor. Someone who has a thin tumor, I'm not going to do that to. But someone who has a 3 millimeter tumor that's at high risk of spread, I'm going to say we should probably assess all four regions. The incisions are small, but they're still incisions. And that's a little bit harder pill to swallow for my patients, but I've got to give the data and say why we're doing what we're doing. So now I know where these lymph nodes are based on these images. Then we go to the operating room. Now, it's great that I've got this here, but if I'm going to make a skin incision, how am I going to find the lymph node based on this picture here? I'm not going to know where that lymph node is. So in the operating room, I actually use a device called a neoprobe. A neoprobe is essentially a gamma detector. It's a wand that I use, and I can put it into the nodal basin, and it picks up radiation, and it beeps. So if I have out here, I'm not going to hear any beeping. The closer I get to the actual lymph node with the radioactivity, it beeps really loud. So I have these auditory cues that I can find it, and I can hone in right on the lymph node and take it out, and we make sure of it. Not only do I use radioactivity, but when the patients are asleep, I then inject around that same melanoma with a blue dye. And that blue dye gets taken up into the same lymphatics and turns the lymph nodes blue. So if any of you have read your pathology report or looked at my pathology report on your specimen, you will see that there's a number, that's the radioactive number, and the level of blue. And that's just for characterization of the lymph node for the pathologist to see. But using the auditory with the radioactivity and the blue for the visual, it increases the sensitivity of getting that correct lymph node. And that's what we want to do. We want to make sure that if I'm taking a lymph node out, it's the right lymph node. And this is the way to do it. So if there's no cancer in the lymph node, again, stage 1, stage 2, early stage. If there is cancer in the lymph node, now we're at least stage 3. And if we've shown that it's stage 3, we've got to rule out stage 4. So that's how I assess for lymph node, but that's only the first part of it. The next thing I need to do is now excise the melanoma. Right? We know that if the biopsy was done, and even if all the margins were clear on the biopsy, if we don't do more to the melanoma, there's a higher risk that melanoma could come back. And we don't want melanoma to come back locally. We don't want it to come back someplace else. So I need to perform what's called a wide local excision. And that just means I'm taking a margin of normal tissue around the actual melanoma. The studies have shown that if you go narrow around a melanoma and just excise it without enough tissue, that it is going to come back, or it's at higher risk of coming back. So we're trying to lower that risk. And that risk is based on how deep in the skin the tumor grows. The deeper it grows in the skin, the wider it can be on the outside of the skin, on the peripheral aspects of the biopsy. So that's why deeper melanomas require bigger excisions. Thinner melanomas do require smaller excisions. But for a thin melanoma, that's up to 1 millimeter in depth, I need 1 centimeter of normal tissue around there. And that's going to give something about the size of $50. For a melanoma that's greater than 2 millimeters, I'm going to need a 2 centimeter margin, and that's going to give something about the size of $1. And I don't just take the skin, I take the skin and the fat below it. I take it down to the muscle. I don't take any muscle, but I elevate that off the muscle beneath. And now you can imagine I've got this big cavity somewhere in your body, wherever it's going to be. Now, how do I get that closed? Well, geometrically, closing a circle is not easy to do. It's going to be elevated edges. It's just going to be hard, a lot of tension. So this is where the wide excision comes. You can see that in the middle of on the picture in the middle, you can see the small dotted circle. Well, first you have the tumor in the middle. There's a circle around it. That's the margin that's been measured out. And then we ellipse the skin to make it easier to close. So that's why people get these long linear incisions on the arm for their melanoma. So for a 1 centimeter margin, it's about a 3-inch incision. And for a 2 centimeter margin, it's about a 5 to 6 inch incision. And that can be pretty significant, especially on some parts of the body. Imagine having someone on your lower leg. I'm not going to be able to close something that big on the lower leg because there's not extra skin. That's where I may have to get plastic surgery involved, doing skin grafts or even flaps. This is a patient of mine here that I recently had, and this is the incision that I needed to do on him. So you can see in the middle of his back, that small oval, that's actually the melanoma. I've measured out a 2 centimeter margin around this, and then I've ellipsed it based on his skin lines and where the least amount of tension is. I also show this because he has a tattoo. Tattoos don't care where your melanoma are. Melanoma doesn't care where your tattoos are. Let's put it that way. And while I try to make it look as good as possible, I really ruin a lot of people's tattoos. Some I can make look okay. This eagle lost a foot and a wing, and there was nothing I could do about it. So, but I am cognizant sometimes if there are linear things, I can try to make it look a little bit better. So that's removing the melanoma. We've talked about removing the lymph nodes, looking for spread, and that's for stage 1 and 2. Once we know you're clear, patients go into observation. Again, if cancer is in the lymph node, we're now talking about stage 3 melanoma. Again, if we identify stage 3, we need to make sure it's not stage 4. So then we do scans. We do PET scans, CT scans. Sometimes we'll even do MRIs of the brain to make sure there's no disease that's hiding in the brain that we can't see. Now, we do operate on patients who have stage 3 disease. That's been well established. It's changing with some of the newer treatments, but we're still operating on these patients. But a lot of the surgery that I do depends on the amount of tumor in the lymph node that I take out. If there's microscopic disease in that lymph node, and usually that means less than a millimeter, there's a lot of times where we don't have to do any further surgery. Just taking out that lymph node could be curative. And then there's a question of whether or not the patient needs treatment afterwards. Because once, as I said before, it gets into the lymph nodes, we're now talking something that's in the system. And maybe you need systemic treatment to help prevent it from coming back. When it's just microscopic disease, there's risks and benefits, and that's a decision the patients have with Dr. Mahmood to decide whether or not it's worthwhile to undergo that treatment. If there's macroscopic disease, and usually we say that's more than 5 millimeters within a lymph node, well, now there's a higher risk that this melanoma can come back and spread, and then we would recommend treatment after surgery. And if we talk about treatment after surgery, that's called adjuvant. We talk about it before surgery, that's called neoadjuvant. So we would consider adjuvant therapy. And then if somebody has a clinically node, that big node that we talked about before, well, then we're going to remove all the lymph nodes to make sure it's not another lymph nodes. And these patients would be considered even for neoadjuvant treatment. I'm going to jump over this real quick. But I do want to talk about for stage 4 melanoma. Stage 4 is when melanoma has spread throughout the body, and people said, well, why can't we cut it out? Isn't this a surgical? Can't we just take out melanoma even when it's someplace else? Well, we have to understand what stage 4 means. Stage 4 means it truly is in your system. And me taking out a melanoma here, when we know it could be other places, that doesn't really give any survival benefit. And so I don't want to put somebody through a surgery that they're not going to have any benefit from doing, except for me giving them a scar. So I need to make sure that the patients are actually going to derive some benefit from me doing what I'm going to do. So yes, there is still a role for surgery in stage 4 melanoma, but it's limited, okay? If somebody has small volume disease, we see a lot of times that melanoma can drop itself onto the skin someplace else or into the soft tissue someplace else, and it can grow, and it can be painful, or it can just be the only site of disease. And if it's the only site of disease, then maybe there is a benefit of actually removing that and rendering a patient cancer-free. Another benefit of taking out a stage 4 melanoma is to see if they're responding to treatment. So if someone's been on treatment and it hasn't really changed, but when you take it out, you can actually see that the entire thing is dead. And we can say, wow, treatment's worked. Doing great, let's stay the treatment. Or if it's still a lot of disease, maybe we have to change treatment, and it can help direct therapy. We also use it for symptoms. I'd like to say that when cancer spreads, we can just take care of it, but sometimes we can't. And sometimes it lands in places that do cause symptoms. I see a good amount of melanoma that spreads to the intestines, that can cause bowel obstruction, can cause bleeding. So there would be a benefit for me to go in to remove that portion of the intestine that has the metastatic lesion there, to allow the patient to get over that and to continue on, especially if it's a bowel obstruction, to start eating again and moving their bowels. Tumors can also be painful. That's a lot of what we see if they're in the armpit, they're someplace else on the chest, and we remove them for symptom control. And so we would need to have a good discussion of the what we're looking at for our outcomes. But if it really will help with symptoms for someone who has spread of disease, then I have no problem removing a stage 4 tumor. Finally, there's areas where we can't operate. The brain, the lung, the liver. Are we going to put somebody through a big surgery for that? Probably not if they have stage 4 disease, but we can consider radiation. And radiation can be focused to that tumor that can control that disease and hopefully reduce some of the symptoms as well. Now, one of the benefits of coming here for treatment, I got to give us a little plug, is that we do everything in a multidisciplinary fashion. You don't just see one doctor here, you see multiple doctors here, but you don't have to see them at the same time. Like if someone comes to see me and I have issues, or not issues, but I see that there's a complex case, we can bring it to a tumor board. And the tumor board is where we're all together. We've got the medical oncologist, the radiation oncologist, surgeons, we've got pathologists, radiologists, and our genetic counselors there. We can all discuss these challenging cases, about the best way to manage. And so if you see one of us, sometimes you're seeing all of us. And it's a really great benefit to the patient to say, hey, we're giving you multidisciplinary care, and we can actually individualize your treatment plan. You've been through 3 lines of therapy. Let's look at the genetics of your tumor. What else can we offer? Can we do injectables? There's lots of other things that we can discuss and develop a plan. Sometimes it's straightforward and we don't need to take it to the tumor board, but a lot of times having this at our disposal really helps us to make decisions and helps you as the patient. And it's important to be able to individualize that treatment plan. Then we also talk about surveillance and follow-up. Coming here means maybe you don't need to see me, the surgeon, anymore. You've graduated from your surgery, and now what's next? Well, we could do survivorship. We can do dermatology. Maybe there's other things that a surgeon may not need, or if you do need me, I can continue to follow you as well. So we have a lot of other options. Dr. Abbott talked about doing some genetic testing of the tumor, and that can help predict risk of recurrence. And so we can do those tests and look to see what kind of surveillance plan should we have. And ultimately, when it comes to those patients who are even the most challenging, they're not responding to treatment and who have spread of disease, we can also consider clinical trials. So hopefully I've given you a nice background of the surgical management. Most of the surgery is going to be for early stage. We do some for later stage, but at the end, after we're done with Dr. Mahmood, we will take some questions.